So hi guys, I hope you all are doing well and preparing well for the upcoming exam. So I am Dr. Sushil, your orthopedic faculty at DBMCI, and today I'm going to discuss the most important topics which have been frequently asked in your FMGE examination. Okay, so here I am presenting to you all the high-yield questions which we have seen have been asked repeatedly, and are the most important concept based or the image based or the, you can say, clinically oriented kind of questions that can be asked to you in your examination. Right, so let's start with that, the high yield questions for the FMG exam. Okay, so first image I'm showing to you, you can very well appreciate here what is the problem with this girl. The problem is that the girl is having this left side forearm deviated medially. Okay, so what exactly is the problem with this child? See, my aim of showing you this image is just to make you understand that, in your exam, the deformity based question. So this topic is from deformity, right? So deformity based question can be asked in variable ways to you in the exam. It can be a straightforward image, for example, like this that you see on the screen, right? Number one. So first point is how to identify a image. I hope you are all aware of it and you have taken the basic classes, you have the basic ideas. So when you talk about the deformities, make sure that you are always looking at the part of the limb which is distal to the joint. Right, what I'm trying to say is that this is the forearm area, right? So the word that you use for the elbow joint is cubitus. Okay, and when the part of the limb distal to the joint, I repeat this line, the first word of any deformity will tell you that what joint is involved. So cubitus is what you use for the joint elbow. When the part of the limb distal to the joint, it deviates medially or laterally, is defined as varus or valgus. Now look at this, the forearm is going medially. So what will you call it? The part of the limb distal to the joint. Which joint? The elbow joint is going medially. So if it is going medially, then it will be known as varus. So the deformity that we see in the picture is cubitus varus. It is cubitus varus. Okay, so this can be a straightforward image based question, or it can be associated with another question which may be somewhat like that this deformity is associated most commonly with which injury. So you should know that cubitus varus is usually seen in a malunited fracture supracondylar humerus. It is seen in malunited fracture supracondylar humerus. That can be a second question. Or they may give you the X-ray picture of the trauma and then they ask you that this fracture may be related to what kind of deformity. So fracture supracondylar humerus usually are related to cubitus varus deformities, right? And you all know that whenever there is an established deformity, if somebody has got an established deformity like this girl, what is the treatment plan? Orthopedics is a very simple branch. Okay, if you don't like anything, just remove it, we'll get a new one. Osteomyelitis, bone tumors, and when you have an established deformity, cut the bone and straighten the bone. So to straighten the bone, what we need to do is different types of osteotomy. So osteotomy will be the treatment plan for this cubitus varus deformity. So one question can be image based, cubitus varus. Second can be the related fracture. And similar to that, you may be asked another like deformity. When you talk about the deformity, supracondylar, the elbow area, when the part of the limb distal to the joint is going medially, then what do you call it? So here, the first word again has to be your cubitus. First word again has to be your cubitus, and as the part of the limb distal to the joint is going laterally now is defined as valgus. So they may give you the image, they may ask you that what deformity it is, or they may ask you that cubitus valgus is related to what kind of injury. So cubitus valgus are usually related to a non-union of the fracture lateral condyle of humerus. Right, now there are so many questions which are associated with this simple topic, that is non-union of lateral condyle. Question that why lateral condyle goes into non-union, that can be very well a question. The fracture of necessity, as it goes into a non-union, these fractures are known as the fracture of necessity. Now what do we understand by fracture of necessity? Fracture of necessity is any such fracture, it is a any kind of that fracture which requires surgical intervention. So we know three major fracture of necessities. One is this itself, the fracture lateral condyle of humerus. Second is the fracture neck of the femur, and third is fracture Galeazzi. These are the three most important injuries which in every case requires surgery. There are or there will be certain other more fracture of necessities but not all 100% cases require surgical intervention. So these three are the most important ones. Please just remember them. The fracture of necessities means the fracture which needs surgical intervention. Now coming back to the topic, why the lateral condyle goes into non-union? Because you know that to your lateral condyle there is attachment of the common extensors which are going like here on the extensor surface, right? So whenever you try to just conserve it, whenever you will try to conserve it, conservative modality is not going to work much. So muscles, the common extensor is going to not allow the fragment to stay in place, and therefore it does not unite. So this is cubitus valgus. Okay, so cubitus varus, cubitus valgus are two most important deformities which basically are the most potential questions for any of the exams. So you must know the reasons, and if they give you the x-ray of the image, they ask you what is the most commonest deformity related, it is varus or valgus. So supracondylar's goes into malunion. Why supracondylar's goes into malunion? Supracondylar area is basically the cancellous part of the bone, right? It is a metaphyseal area of the bone, it is a cancellous area of the bone. So it has high potential of union because we know metaphysis is highly vascular, right? So it is a metaphyseal area, and all the cancellous areas, they have huge potential of joining, or I can say getting healed up. So the Colles fracture, fracture distal end of radius at its cortico-cancellous junction, that also unites very well. This one, supracondylar, will also unite very well. Boxer's fracture, metaphyseal, unites very well. Jones mostly unites very well. So unless there is a pull of some tendon over the bony fragment, usually the bones heal very well. Okay, this is something you have to keep in your mind. So deformities will be very important in this way, right? So moving on to the next part. Okay, so second topic I'm taking after the deformities is coming on to the metabolic disorders. See, when I tell you about metabolic disorders, the two most important topics for the exam purpose, I must say, in the metabolic disorders, they are, one is osteoporosis. One will be osteoporosis, from where the questions have been frequently asked, or second will be the disorder of mineralization. You know that the disorder of mineralization, it can be rickets or it can be osteomalacia. So majority time you will see that most of the questions are directed either to your osteoporosis or to your rickets, right? Maybe a disease related question, maybe a treatment related question, maybe brace support, maybe something like that. Okay, so let's first talk about the osteoporotic part. So osteoporosis, guys, you all must remember all the important points about osteoporosis. For example, what is the most common site involved in osteoporosis? Why and how the patient comes to you clinically? So patient in osteoporosis, they have the most commonest involvement at either vertebra or at neck of femur, or in the upper limb, it is distal radius. Now, what is common between all the three sites? The vertebra, the neck of femur and the distal radius, that these all three are cancellous regions of the bone. So when you have the cancellous areas of the bone, they have more potential of getting damaged. Okay, and in distal radius, which is the most commonest fracture seen, it is usually Colles. It is usually Colles injury. So what is the most commonest presentation of these osteoporotic patients? It is usually pain at all these sites. Now this pain can be like traumatic or atraumatic. Okay, it can be, I can say that it is atraumatic, without trauma it is happening, or it is traumatic. So when it is without a trauma, the vertebrae are causing pain to an old lady. If you have ever observed your grandmother, when she was young, the height was little more, and when now she is old, the height is gradually little bit decreased. Why? Because the vertebra is your weight transmitting bone. So all the weight of your skull, brain matter, upper limb, it is to go down to the lower limb through your vertebrae only. So you see here that all these intervertebral levels, if you can observe them, they are showing you one typical kind of picture. What is this? Now this is to be observed that this is a diffuse kind of change at all the vertebral levels. This is a diffuse kind of change at all the vertebral level. What do we call this? This atraumatic presentation is known as the codfish spine appearance. Again, a very, very potential question for your exam. The codfish spine appearance. So please remember that codfish will not be a localized thing. It has to be a diffuse thing all through the vertebra, because all vertebrae are taking weight. Okay, and if it is traumatic one, then it can show you compression fractures of vertebra, for which obviously they can't make a straightforward kind of question that some vertebra is given to you which is compressed and they ask you what is the diagnosis. So diagnosis will be compression fracture. Reason can be any. It can be osteoporosis, it can be trauma, anything. So when there is a traumatic kind of injury, there is compression fracture of the vertebra. So please remember, this is what you call as a codfish, and a huge potential of being asked in your exams as well, the codfish spine appearance. Okay, now how will you diagnose a patient of osteoporosis? How do we diagnose this picture that you see on the background? It is a codfish. Okay, how do you diagnose the how do you diagnose the patient of osteoporosis? So diagnosis, guys, is very simple. Please do remember, it's again a very important point and concept that in osteoporosis, the serum mineralization actually usually are normal, because the problem is now in the bones. It is not in the serum, or it is not in the mineralization component. The bone itself is getting defective because it's an age related process. So with aging, every cellular activity has to slow down. That is what osteoporosis is. So how to diagnose osteoporosis? The gold standard to diagnose osteoporosis is what you call as the DEXA scan. It is known as the DEXA scan, where what we do, we check for the bone mineral density. So after what age it is mandatory to go for DEXA scan for any patient? After 65, it is mandatory to go for, or it is basically not mandatory kind of thing. We should say it is advisable to get every lady evaluated routinely. Right, as a part of routine investigation, every lady should be examined for DEXA scan. So BMD after 65 years of age for every lady is recommended. So what we measure in the DEXA scan? We measure in the DEXA scan is something known as the T-score. And what is the T-score? In first, it tells you what is the information. So T-score, anything better than -1 is considered normal. If the T-score comes up between -1 to -2.5, it is considered osteopenia. That would be osteopenia. And anything going less than -2.5 is definitive osteoporosis. So when the T-score goes below 2.5 is what you definitely call as osteoporosis. That's what you call as osteoporosis. Okay. So how do we treat osteoporosis? That also you should know. So osteoporosis, treatment will be, you have to give a combination therapy together, which will not allow the further resorption of the bone, as well as which helps in increasing the formation of the bone. So category number 1 is what you say, the drugs which inhibit resorption. The drugs which inhibit resorption. What are the drugs which will inhibit resorption of the bone? The drugs which inhibit resorption of the bone, they are, number one are the most important ones are the bisphosphonates. It is always remember that bisphosphonates are usually the first line of management in any osteoporosis patient. Second one is calcitonin. It is a nasal spray. Okay, calcitonin is available as a nasal spray. Number three, it is estrogens, and number 4 is selective estrogen receptor modulator. So please remember the 4 categories of medical management which basically inhibits the resorption of the bone. Second category we say is the drugs which are going to promote the formation of the bone. Second category is the one which is going to promote the formation of the bone. So what are the drugs which promote the formation of the bone? The drugs which promote the formation of the bone, they are number one is teriparatide. So what exactly is teriparatide? Teriparatide is your synthetic PTH. Don't forget this. It is a synthetic parathyroid hormone. It is a synthetic PTH. Second is calcium. Now, what is that calcium? How much to be given? What is to be given? Usually we give like 500 milligram OD, but the requirement of calcium per day is approximately, it can go depending on the age of the patient and the requirement of the patient, it can go up to 1000 milligram to 1300 milligram. Okay, so calcium is there, and then we have the calcitriol for the proper absorption of the calcium. Okay, these are 2 categories which have to go together. Another drug that we have is known as denosumab. Now, what exactly is that denosumab? Denosumab is a rank ligand blocker, right? It inhibits your rank ligands, and if you have the knowledge of that rank ligand, if you recall that, you can just remember that. So rank ligands, they are basically responsible for the activation of the osteoclast. So this indirectly is going to block the osteoclast itself, right? And we have one drug which has got like dual action, which is known as strontium renylate. So strontium renylate has got a dual action. It has got a dual action. Okay, it has got a dual action. So this is all about the osteoporosis that you have to recall, you have to remember. Every line mentioned over here can be used to or utilized to make a MCQ for you. Okay, so these are all about osteoporosis. Let's see the next one. Okay, so next one you can see, guys, here is a deformity, right? It is coming from the topic of nerve now. So deformity here is basically what you call the arm is close to the body, this elbow is extended, the forearm seems to be in pronation, and the whole limb seems to be in the internal rotation. I should make it like, instead of like this, I should make it like this one. So this has gone into internal rotation. This is what you call the policeman's tip deformity. That's what you call the policeman's tip deformity. In the policeman's tip deformity, you know, the nerve root involved, they are C5 and C6. The nerve root involved are C5 and C6. Nerve root involved will be C5 and C6. Okay. Now, this Erb's palsy, this is what you call as the Erb's palsy. You must know that Erb's palsy, how the patient presents to you and what is the commonest site of injury. For Erb's palsy, we all know the basic concept that this is the most commonest nerve injury. This is the most commonest nerve injury that occurs during what procedure? That occurs during delivery. This is the most commonest nerve injury which occurs during delivery of the child, right? And you also must remember, guys, that this Erb's palsy is most commonly a neuropraxia. That means it's usually just a stretch or a physiological block. So here the recovery usually expected is complete. The whole action, all the actions of the involved muscles will be improved. Okay. Sometime if it is a transaction, we have to go for surgical intervention. This is what you call policeman's tip deformity, where the arm, here is adducted. You have to remember it like that, where the elbow is extended, where the forearm is pronated, and limb overall is in internal rotation. Right? This is how the Erb's palsy is defined, internal rotation. So if somebody asks you that what is lost in Erb's palsy, then elbow flexion is lost. Okay, here the adduction is there, so abduction is lost. Here it is pronation, so supination is lost, and it is an internal rotation, that means external rotation is lost. So you can say in Erb's, the fibers is lost, F-A-B-E-R. So flexion, abduction, external rotation, supination is lost in Erb's palsy. It is lost in Erb's palsy. That's we can recall, right? So this was about the deformity part. So deformity, I have told you about cubitus varus, cubitus valgus, Erb's palsy. Similar thing, you should always be able to recall the deformities related to your median nerve and ulnar nerve. Right? You must always be able to remember the deformities of median and the ulnar nerve. Now coming on to that again, this one, what do you observe here? The patient is trying to, or is having all the other fingers flexed, but one of the finger is extended like this. You should know that in the hand, when you talk about the hand region, you might be, having this idea already. I do believe that. I'm sure about it. So 1, 2, 3 and this 3.5. This 1, 2, 3 and 3.5 is basically your median nerve. This 1.5 is your ulnar nerve, right? So 1.5 and 3.5 is, this one is having the divided one supply. Okay, so 3.5 and 1.5. Here what you are observing is the patient is trying to flex all the fingers and this one is remaining extended. So this is in the territory of which nerve? This is what you call as the pointing index sign. This is what you call as the pointing index sign. And this pointing index sign basically, guys, is a failure of, they can ask you that the patient is having palsy of which nerve. So please remember, it is falling in the territory of median nerve. So it's a failure of the median nerve. It's a failure of the median nerve. Okay, simple thing, it's a failure of median nerve. So this is pointing index. Another test that you must remember from the median nerve itself, one is this pointing index. Second is when you ask the patient to hold something between, like this pad I'm having here. So you ask the patient to hold something between the thumb and the fingers like this. Okay, so this, don't forget this one. When you ask the patient to hold it like this is the adduction power of the thumb. So please remember that the adductor pollicis is a exception. The adductor pollicis, this thumb, this is in the territory of the thumb, agreed, median nerve, agreed, but this adductor pollicis is a supply of the ulnar nerve. So this is an exception, please don't mix it. This is usually your MCQ. So adductor pollicis, ulnar nerve. And for this adductor pollicis, the test I have tried to do, holding this pad between the thumb and the finger like this is what you call as the book test. And if the patient is not able to hold it, what the patient does, he tries to pinch it. Okay, he tries to pinch it. So he will try to pinch this. So instead of adductor pollicis, he is going to use flexor pollicis. So flexor pollicis is for sure being supplied by median nerve, right? So do remember, adductor pollicis is an exception muscle. Ulnar nerve which basically is in the thenar side but being supplied by the nerve of medial side. Okay, so this is an exception here. So pointing index sign, adductor pollicis, the test being done is known as the book test, and if a patient is using use of flexor pollicis to hold the object, use of flexor pollicis to hold the object is known as the Froment sign. It is known as the Froment sign, right? That's known as the Froment sign. Okay, so this is about the hand important test, the Froment sign, the book test, pointing index sign. This is very, very important. Okay, guys. Now, one other thing, keep that point in your mind very, very clearly. You might be given another kind of question here where, okay, in relation to this only, I wanted to tell you this. Okay, no problem. I'll tell you from here only. So, in relation to this only, you must remember that if you, in this picture, what you are seeing, in this picture, you can see that the patient is trying to flex all the fingers and this one is extended. So, median nerve palsy. Now, on other hand, if you ask the patient to, flex, if the patient is coming to you and you are asking the patient to flex all the fingers and this remain extended, that means it's a median palsy. But in case the patient comes to you with this kind of hand, if the patient comes to you with this kind of hand, all the 24 hours is having this kind of hand, this means it is a ulnar nerve involvement. That means it's a ulnar nerve involvement. Okay, and you must remember that the ulnar nerve basically this injury, ulnar claw hand, it will not be causing a complete claw hand until unless both the median and the ulnar are resected here. So if a patient comes to you with a hand like this, that's an ulnar nerve palsy. When you ask the patient to flex all the fingers and these two remain extended or this remains extended, it is median nerve palsy. That is a difference. So ulnar claw, please remember the difference in an ulnar claw and a median, this pointing index. So ulnar claw is a ulnar nerve palsy, 24 hours the patient's attitude is same. Pointing index, the median nerve will be like when you ask the patient to do it, then he will be able to do. Then he will not be able to flex this finger. That is pointing index. Please remember the difference in the two injuries. Okay. Then you have this picture. What do you appreciate here? What do you see here? So you can very well appreciate that there is a flexion contracture of the wrist, of the finger, of the phalangeal area here. Everything is flexed. What do you think it is? Seems like a claw, right? Isn't it? Seems like a claw. And this claw can be like a complete, you can say, this median plus ulnar nerve injury, right? That is one problem. Okay, or this kind of contracture can be a part after a injury to the limb where the limb has produced raise in pressure. That's known as compartment syndrome. That's known as compartment syndrome. Okay, so you must remember about the compartment syndrome all the point. This is what you call Walkman's ischemic contractures, right? This compartment syndrome finally lands up into this kind of damage, the Walkman's ischemic contractures. So everything will be like this, flexed, fingers flexed, like the picture which has been shown to you, right? This can be a complete claw as well. This can be compartment. So do remember that how they are giving you the history of trauma or the nerve involvement or nerve resection at the wrist area. So guys, let me talk to you about the compartment syndrome. In the compartment syndrome, you must remember that the most common fracture associated with compartment syndrome, the most common fracture which very, very often leads to compartment syndrome is fracture diaphysis of tibia. It is fracture diaphysis of tibia. That is point one. Okay. Second, the most commonest muscle, earliest one to get into compartment syndrome is FDP. So I must say the most common muscle to get involved is flexor digitorum profundus. Third point is whenever there is a compartment syndrome, the pressure, to call it a raised pressure, is 30 millimeters of mercury. It is 30 millimeters of mercury. Number 4, the most commonest nerve which is related to compartment syndrome is interinterosseous nerve. And the most important sign that would be related to compartment syndrome will always be the pain on passive stretch. Right, the pain on passive movement is the most important sign. And when you are talking about the treatment plan, so please remember in the treatment plan, fasciotomy is the treatment. Fasciotomy is the treatment, and here the fasciotomy should be superficial as well as the deep. Both the fascias have to be resected. Okay, these are the questionnaires about compartment. You must remember that. They may give you one image of fractured tibia and they may ask you that what is the most commonest complication related to this particular fracture. So complication can be like diaphysis of tibia can most likely cause or is most commonly known to cause compartment syndrome. So you should be very, very watchful about that. Okay, that is one. Now here, what do you observe? Here what you observe is a splint which has been applied where the fingers, or these are what the metacarpophalangeal joint areas, right? So here the knuckles, these are what you call knuckles. They are bent here to make the extension for the fingers. The knuckles are bent to get the extension for the fingers like that. Okay, so this is the knuckle bender splint. And why do we use it? Like if it is a claw, we can talk about the claw hand. It can be ulnar claw or median claw, a claw like that. If it is not traumatic one, this is though a VIC compartment syndrome. This can be, the presentation will be, the claw will be same, right? Complete claw hand will also be same. Presentation is same. So if it is the claw hand, what kind of splint to be needed? The splint which can keep the finger extended, and these MCPs which have flexed into extension. So when the MCPs have gone into extension here and IPs into flexion, that has produced your claw hand. So what we need? We need a splint which can keep MCP here like flexed and IPs extended. So knuckle bender splint. Okay, if this is a complete claw hand, let's say, after the nerve injury, then we can very well use the knuckle bender splint. So it has to be used for claw hand for any reason. So contractures are to be avoided. Okay, next one is like this. This is your what you call as the wrist fallen down, the wrist drop. And you must remember why there is usually a wrist drop. So why there is usually a wrist drop? Why should be there a wrist drop? A wrist drop is because of involvement of the radial nerve. Now in this picture you can see extension of the elbow is maintained. That means the radial nerve injury has happened below the spiral groove. It has happened below the spiral groove. So injury has happened below the spiral groove. Had it been above the spiral groove, that means the tricep should also have been affected. And if triceps would have been affected, that means extension of elbow has been affected. So it is below the spiral groove, not in the axillary area, not in the spiral groove area. It has gone below. That means the injury involving the shaft of humerus. The injury involving the shaft of the humerus. So that's radial nerve. That is a wrist drop. Okay, that is the wrist drop. So what kind of splintages is to be used for this kind of wrist drop? The splint to be used is the one which can keep your wrist extended. So here you can see one of the splint is keeping the hand in a fixed position, right? This one is known as the static splint. It is known as the static splint. Okay, so both of these are what kind of splint? These are known as cock up splint. Why are we calling it a cock up splint? Because here you are keeping the wrist in an extended state. This one on the other hand is like this. Now here what do you observe? The springs are applied. Now this, when you have the springs, this splint is known as the dynamic splint. This splint is known as the dynamic splint. So what is that dynamic splint here? What about dynamization? Means you are able to move. So patient is having a problem of wrist drop. So you have given the splint which will keep it like this. Okay. Now because of the spring, the patient can ask, you can ask the patient to just flex the fingers and wrist accordingly. So when he does so, the splint will take it back. So exercise, physiotherapy has been allowed so that there is no muscle wasting which can be avoided. So this dynamic splint has been a question in your past as well. So you must just remember this fact. Whenever the spring is applied, it is a dynamic splint. Whenever the spring is applied, it is a dynamic splint. So cock up splint or the static splint, dynamic cock up splint, it can be any, right? So whenever in any splint the spring is applied, for example, if you have seen this one, if you observe this one, here also a rubber band has been applied like this, keeping these two together, right? Keeping these two together. So this one is a dynamic one which doesn't move or no mobilization allowed, is a static splint. Okay. Next, what do we have? Okay, so we have a polyp-like growth coming out from the tumors. So guys, my suggestion to you for the tumors is always follow the sequence. Now, what sequence is to be followed? Whenever you have a question about tumors, just see first of all the location. And for the bone tumors, I have already shared one image on my Telegram group, which you all can just go there and download that picture, the location of the tumor, then try to identify the nature of the tumor and see if you are able to see any special feature in these tumors. So any special features in these tumors. So location here, is epiphyseal, this is metaphyseal, and a polyp-like growth is coming. We know polyp-like growth like this is only seen in one tumor, and that is osteochondroma. Why it is not a osteosarcoma or Ewing sarcoma? Because you don't see any periosteal haphazard response over here. That is why this is osteochondroma. So go for the location, go for the nature, and go for the special feature. Location, epi, meta, die, you can easily identify. Then going for the nature, what you have to do? Just see if you are able to see any kind of periosteal response, any of the periosteal reactions, It is not there again, so it has to be benign lesion. Special feature is that it's a polyp-like growth which is going away from the bone, and you see this polyp is going away from the joint line. This is osteochondroma, right? This is osteochondroma. So do remember follow the tumors in the same sequence. Always try to follow the tumor in the same sequence, right? This is to be done. Then if you observe this one again, let's follow in the same sequence what we have talked about. Number one, I said location. So always go in the same sequence. So going for the location, what is the location here? Here the location is epiphyseal. Okay. Look at or try to find out the nature of the tumor. So when I look at this, when I look at the lateral side, I can feel that the cortex is usually, maintained. Seems like a benign lesion. If you see the other side, the cortex is already broken. So that means it's a tumor which has the potential to damage the bone locally. So what kind of tumor it is? So nature, if I talk about this tumor, the nature of the tumor falls in the category of benign aggressive lesions. So these are benign aggressive lesions. And special feature, can you see something? The lesion which has got septations and these kind of, these vacuoles here, they are known as what? This is what you call as the soap bubble appearance. That's what you call the soap bubble appearance. So epiphysis, benign bone lesion and soap bubble appearance. What makes this? This is giant cell tumor, right? And what's the other name for giant cell tumor? We know it is osteoclastoma. It is osteoclastoma. So giant cell tumor or osteoclastoma. Okay, so that is the way to go out to any tumor. So osteochondroma I have shown you, giant cell tumor I have shown you. They may give you, this has been done already in past for you guys. So you must remember that they may give you some pathological specimen and how to go, same sequence. Where is the lesion located here? So don't get panicked or focus here directly. Just see the end of the bones. See, epiphysis seems to be clean. It is okay. And here we have the diaphysis is this area, shaft area. And you see this metaphyseal area is showing you a growth which is like all the metaphyseal area, cortex is broken, So tumor here is metaphyseal. Tumor here is metaphyseal. Second tumor here is metaphyseal. Second here, it is breaking the cortex. So falling in category of what? Aggression. That means it's a aggressive tumor, or I can say simply it's a malignant tumor. So what is a malignant tumor which is seen like this at metaphyseal area? There is only one, and that is osteosarcoma. So don't keep that point in your mind that only I am able to see the sunburst appearance, then only I'll call it the sunburst appearance is a radiological finding. This is a pathological specimen. Okay, so in this you are able to see a growth at metaphyseal area, and that makes it fall into the category of osteosarcoma. So please keep that point in your mind, right? So metaphyseal, aggression, malignant, and osteosarcoma. So please follow this sequence. Don't break this. Now see this. This is the radiology. Same tumor, when you see that, on the X-ray, that will be seen. So that's what you call sunburst appearance. So don't remain fixed to the theory that what I have just, seen in the books only. Some logical things have to be applied. When the pathological specimen is given, don't get panicked. That's okay. So always start from the end of the bone. Always start looking from the end of the bone, and you will come to know it's a metaphyseal area, epiphysis clean, going towards diaphyseal area, breaking the cortex. If it is breaking the cortex, periosteal response is so aggressive that makes it a malignant tumor. Okay. So what we have next? This one. So what do you observe? What do you observe here? You can see that multiple layers of the bone parallel to the parent bone. So what exactly this tumor falls into category? This is a central part of the bone being shown. So area shown is diaphysis. Okay, benign or malignant? Why now I cannot call it benign? Because you can see multiple flared up response of the periosteum. So it is a malignant tumor. And what is the special feature you are able to see here? Multiple lines parallel to the bone. Multiple parallel to the bones. So this picture is what you already know is known as onion peel or lamellated appearance. Onion peel or the lamellated appearance. So diaphysis, malignant, onion peel, and the lamellated appearance. What makes it? What makes this tumor? Being called as Ewing's sarcoma. So this is Ewing's sarcoma. That's what you call Ewing's sarcoma. Okay. So diaphyseal area, malignant lesion, onion peel lamellated. This is Ewing's sarcoma. Okay. So guys, if you are given a clinical case in your exam where they say that a child is there who has got a tense tender swelling in the middle part of the thigh, middle part of the leg, middle part of the humerus. You know that these tumors usually occurs in the lower limb, so femur usually. So middle part of thigh means diaphysis of the bone. So don't get carried away or get afraid of the language of question. That's okay. Follow the same sequence. Location, try to know the nature. If they say that the child is having like high fever, ESR raised, and so many other things like which shows you or which tells you that the problem has been a chronic one. So in that case, you know it's a malignant tumor. And if the tumor is malignant, at diaphysis, it's only Ewing sarcoma. At metaphysis, it is only osteosarcoma. No other malignant tumor is usually asked in exams. So two malignant tumors you'll have to remember. Ewing's at diaphysis, osteosarcoma at metaphysis. So go with the same sequence all the time. Same location, nature, and the special feature. I hope the points about the bone tumor is clear. Okay, moving on to the next picture. Why I am discussing the theory with the images? Because nowadays images are like more frequently being asked, whether it is about splint, whether it is about disease, whether it's about some kind of implant like that. So let's see next one. So if you get a picture like this, patient having pouring discharge and all, everything, this central portion will be known as what? So this picture is basically an image of chronic osteomyelitis. This is an image of chronic osteomyelitis. This is a picture of chronic osteomyelitis. Okay, so chronic osteomyelitis, number one is what you call sequestrum. So what exactly is a sequestrum, guys? This one, this is a dead bone, right? That's a dead bone surrounded by granulation tissue. A dead bone surrounded by granulation tissue, right? That's a dead bone surrounded by granulation tissue. Where is the granulation tissue? This all area. This whiteness that you see here is the second feature of chronic osteomyelitis, which is known as involucrum. So how do you define involucrum? This all whiteness that you see, this all whiteness all around the infected area is involucrum. So how do you define involucrum? Involucrum will be defined as a reactive new bone formation. It is defined as a reactive new bone formation. So reactionary new bone formation is involucrum, right? And this break here that you observe is known as the cloaca. What is a cloaca? Cloaca is an aperture or an opening into the involucrum from where the granulation tissue goes out, right? So this is an aperture in involucrum. This is an aperture in involucrum. Okay, so chronic osteomyelitis. Please remember, this is the pathology for which we do the surgery of removing the infected foci first. First, we have to remove the infected foci. Therefore, the treatment here will be, first is always sequestrectomy. First is always sequestrectomy plus saucerization. Sequestrectomy plus saucerization. So, saucerization is what? When you remove this all dead bone, a space is created here. A space will be created here, right? And that space is what you call as sausage shaped space. Saucerization, that is a space being created after the cleaning of the infected cavity, right? Sequestrectomy and saucerization. Okay, now next one, what do we have? So in this image, guys, what you're able to see is the finger getting flexed at the last IP joint, and there is a extension, hyperextension, I must say, at the proximal IP joint. So DIP and PIP, like that. So distal IP joint and PIP. What deformity is that? I hope you all are able to recall the deformity. It will be your swan neck deformity. Where do we see this swan neck deformity? The swan neck deformity is seen in cases of what problem? What arthropathy? That is rheumatoid arthritis. And here, what is this deformity? The PIP getting hyperextended and the DIP getting flexed. So this is the flexion here, and this is hyperextension here. So flexion at PIP and extension at the DIP. This is what you call as the botonier deformity. So upper one, the swan neck, and this one, the botonier deformity. Both of them, they are being seen in what problem? They are being seen in rheumatoid arthritis. They are being seen in rheumatoid arthritis. Okay. Now, next one, yeah, this one, classical case. What do you observe? Anterior part of all the vertebrae, they are fused. Okay. And these vertebral bodies from the sides, you see them, this one, this one, this one, this one. These are all fused. So what is that? What will that be known as? That will be ankylosing spondylitis. They will be ankylosing spondylitis. So what actually that means, ankylosing spondylitis? Itis, you know, when you say itis, it is for inflammation. Spondylo is for vertebra. Ankylosing means the fusion. So when there is a pathological fusion of the spine, that's what you call ankylosing spondylitis, right? And this condition is very, very common in the male young boys, 15 to 25 years. And first joint involved in ankylosing spondylitis, please remember, it is sacroiliac joint. That would be sacroiliac joint. Okay, this image is very important, has been asked in different exams as well. So high potential question for your exam too. Next, this one, what do you observe here? What do you observe? What is this deformity? The CTEV. The points to be remembered about CTEV is that the deformities which are seen in CTEV, how they are corrected and what are the deformities seen. So I am giving you this mnemonic here, the cave. This is to be remembered. The deformities seen in CTEV, they are cavus, adduction, varus and equinus. And they ask you that what is the order of correction of the deformity, then order of correction of the deformity is also same, the cavus, adduction, varus and equinus. When these four deformities combine, you can see that the foot automatically goes into the state of inversion. What is that inversion? When the undersurface of the foot can be seen on the medial side is what you call inversion. Is what you call inversion. So this is CTEV. In CTEV, you know, the treatment plan followed is according to Ponseti guidelines. It is according to Ponseti guidelines, right? And for the correction, after you have given the correction cast, you know, in this sequence you have to correct it. So one plaster has to be changed like every week, and for 7 plasters, within 6 to 7 plasters, you should be able to correct the deformity. Now, when you are like treating the CTV patients, this kind of splint will be required. Two shoes connected to each other by a bar, and what do we call it? The CTV splint or the Dennis Brown splint. So please remember the images of these two as well, the Dennis Brown splint or the CTV splints, right? This is worn initially full time, and once the child starts walking, then it can only be given like only in the night time. Okay. Now coming on to the instruments which are important for orthopedic point of view. So the first one you can see, you have a thumb rest over here, right? When you have a thumb rest, it is your periosteum elevator. This is periosteum elevator. You can very well get confused between a periosteum elevator and a chisel. So chisel would be almost similar, but that doesn't have a thumb rest. So when there is a thumb rest, it is being given so that you can put your thumb here and scrape off the periosteum. That would be periosteum elevator. This one is a chisel, and chisel can be confused with osteotome. So remember that in osteotome, both the margins, upper margin and lower margin here, you can see upper margin and lower margin here. In osteotome, both are sharp. Both are sharp. And in chisel, one of the margin is sharp, other one is beveled one. Right? That is the difference in osteotome and the chisel. So don't confuse between them. This is the picture of a chisel seen from the side. The osteotome, this is osteotome, sorry, my bad. The upper one is osteotome, and chisel will be only sharp at the one end, other end will be beveled one, like that. Okay, that is a difference. Then we have these small pins like wires basically, which are sharp at both the ends. The size here starts from 0.5 mm to 3 mm at last, right? So 0.5 mm to 3 mm at last, diameter, thickness. Okay, these are known as what? K wires. And what is the purpose of these K wires? The K wires are being used whenever you want to do internal fixation without opening the bone. That is usually close reduction and internal fixation. So these can easily pass into the skin directly. Okay. This is the crocodile like, you know, these apertures here. What do you call that? This is what you call the bone nibbler. This is what you call the bone nibbler, right? That is bone nibbler. So you have basically, you know, to nibble out bone, extra pieces of the bone, you hold it and you just pull them. That is bone nibbler. Okay, what splint support is this, guide? This is the splint which is used for stabilizing the fracture shaft of the femur while you want to transport the patient, or while you want to just keep it them like with you to stabilize the fracture shaft of femur. This is what you call as the Thomas splint, designed by H.O. Thomas. So Thomas splint basically, you know, on the lateral side there is always an angulation here to accommodate the greater trochanter, and this ring is never straight, it is always like slanted, right? It is almost slanted with the angle with the inner part is almost like 120 degrees. That's how it is made. So Thomas splint is used for stabilizing the fracture shaft of the femur. If you want to transport the patient, if you want to keep the bone immobile in your wards or somewhere till the OT is being done, this is Thomas. Initially, it was designed by H.O. Thomas to stabilize the knee area of his own wife who was suffering from tuberculosis of the knee. Okay, the brace support here, you can appreciate on the back of the child. What is the problem here? What is the pathology here? That is scoliosis. And this one is known as what? The Milwaukee. This one is known as what? The Milwaukee brace, used for scoliosis in children. used for scoliosis in children's. Okay, that will be used for scoliosis in children's. Please remember. Right, one other traction where the child has been hanged like this for stabilizing the fracture shaft of femur. In whom? In a child less than 2 years. What do we call it? It is known as gallows traction. This is known as gallows traction. So these are certain important traction systems which you must remember. For fracture shaft of femur in less than 2 years old child, we can use gallows traction. Okay, so this is gallows less than 2, not beyond that, because more than like till 5 years, you can say till 5 years of age. Yeah, till 5 years of age, what can be done is hip spica. What can be done is hip spica. Okay, so yeah, so this one, yeah, one more, we have one important X-ray image. What do you observe in this particular image? You can see that the metaphyseal area is very irregular and it is widened as well. The bones seems to be widened. See the metaphyseal splaying and the fraying. So what exactly is this pointing out to? So this is an X-ray of rickets. So I told you osteoporosis, osteomalacia, rickets, mineralization disorder and osteoporosis itself is a very important topic when you talk about their FMG examination. From here we expect like a image based or a theoretical something will be there for sure in your exams. Okay, so guys, I think that is all I have for you. I am very much available. Your exam still is like having some time. So in case you require any kind of assistance, doesn't matter whether you are a DBMCI student or a non-DBMCI student, doesn't matter. Feel free to reach out to me if you want any kind of academic assistance from my end. I'll be more than happy to help you out. Okay, and I do believe you all are preparing well without any apprehensions, without any fear. Just keep focus on your basics, and if the basics are strong, believe me, only basics are required, not only for FMG, for your NEET also, AIMS also, INI basically, the next also. Basics are must, the concepts are must. So stay focused onto the concept and believe me, all your questions will be like, just a piece of cake for you. Okay, so keep preparing, have faith in your preparation, have belief in yourself, and I'm sure you are going to go through. Okay, so all the very best to all of you guys. Thank you so much and just do your best in the exam.